next topic, which is the role of OCT in glaucoma. And that is something extremely significant, extremely important, and can make a lot of difference to early diagnosis. So we have Dr. Sagarika Patel. She's Major General Sagarika Patel, one of the senior most ophthalmologists from the Army. She's working now in Center for Sight as one of the lead glaucoma specialists in our center.
How and what are the problems and how to interpret OCT and in order to help our glaucoma diagnosis. And I would invite questions, because when you ask questions, then it also helps us to think and give you an answer. So why do we image? Because basically we want to create the foundation for diagnosis. Like you have a clinical examination, similarly we want to image in order to see what my optic nerve is like, what my RNFL is like, and what my macula is like. So therefore, I'll be able to get an objective, quantitative, precise, reproducible. I do it once, I do it again. I'll get the same thing. Of what all? I'm getting 3 structures in one go. I'm looking at the optic nerve, I'm looking at the RNFL, I'm looking at the macula. And macula holds immense promise for us to diagnose early glaucoma. And therefore, we also have software in order by which we can measure change over time, because we know glaucoma is a progressive disease, it's a chronic disease. We want to know, is it progressing or not? Plus, we also are able to find out, statistically determine whether the structural features of ONH as well as of RNFL of a given individual fall within or outside the normal range, and whether there's a statistical significant change has occurred over time. Now, how do I get a good scan? That is the most important tip, in which I would like you all to pay attention to. First of all, choose the right scan protocol. We want something fast, so you just remember the word fast. Fast, minimize motions. Therefore, the artifacts which are caused because of motion, that gets eliminated. Ask the patient to sit comfortably. Adjust your scan position, your scan position, your patient's fixation. Your scan ring adjustment has to be right on the optic nerve. You have to check, very, very important, check for signal strength. If you find, you must check if the patient's eye is dry. Put 1 drop of artificial tears, which you must keep near your OCT machine. Dilate the pupil whenever you want to take the entire scan at one go. Check, moment you get the scan, check if there are any black areas in the scan. Black areas means there is missing data. Check the signal profile analysis, the disnet double hump, asymmetry of the discs, and asymmetry of the RNFL thickness quadrant sectors. Check whether it is correlating with your visual function or not. Involve the patient that look this way, so that the patient also helps in improving your scan. Along with that, please do not forget to consider the cost that it involves in this. Don't rely on colors. Ye lal hai to kharab hai, ye green hai to acha hai, etc., etc. Please confirm the normalcy of the data. So do not look for color, just do not look at color. Loss of 5 millimicrons is equivalent to loss of 1 lakh GCCs. You have to do a clinical examination. Without clinical examination, an OCT is of no use. Combine analysis of both the GC-IPL as well of the peripapillary RNFL. That is why take a composite scan. It performs better when you're using each individual parameter on its own in early glaucoma. So you take a lot of things, you're able to analyze better. Remember, all tissues affected by glaucoma, they can be evaluated by OCT. That is why in this long length of time with all the imaging devices, OCT has stood the test of time. Now let's have a look at the types of commonly used types of analysis, the printouts that we get. The first one, as we can see, is an OCT, then the OCT by the OptoView. The second one, that's the middle one, is mainly by the Cirrus, which we are all very commonly we commonly see, and the third one is the Spectralis OCT. Now, Spectralis is an expensive OCT. I don't have the time to carry on with that, but however, let's see how much I can tell you. So first of all, the scanning protocols you must know. You have to have a macular scan in which you have a 6 mm radial line scans are there. Then you have an RNFL scan there are three 1.73 millimeter radius circle scans, and you have an optic nerve head scan, very, very important. Now, each OCT, it curates a ring scan of its own. That means don't think what a Cirrus is going to, the ring scan will be the same as Spectralis or the same as OptoView, because in a, let's say, RTVU, which we are commonly using, the scan that goes around the optic nerve head, it is 3.45. Cirrus is very close by, it's 3.46. What about Spectralis? That gives you an additional advantage. He says, choose your scan. So you can have a diameter of 3.46, 4.1, 4.9. So that's a great advantage. Let's just talk about the Cirrus OCT, how to interpret it. Your first thing should be going at your demographic data. Is it of the same patient, age, name, ID? Then you must look at this, the strength. If your signal strength in a Cirrus OCT, as per the manufacturer, if it is 6 and above, or let's say 7, then it's of good quality. Otherwise, if your scan is of bad quality, it's of no use to you. So please look, where is the scan? Where should you look? Look right at the top. I've marked it in red. So I've said image quality is measured by signal strength of 7 and or more. That's of good quality. Now, you are in this, you have to look at, I'm with the cursor trying to show you, is my cursor working? No. I wish I had a bit of, it's working? Okay, so now please let's have a look at the topmost thing. In the topmost one, this is the only image you get where a statistical analysis is not taking place. It's the actual image of the patient's optic nerve with the retinal nerve fibers. Now, if you look at the what is hot, red is hot. What is hot? Yellow is partially hot. What is not hot is blue, the sky blue. So therefore, we look at the hot colors. Remember, in the top and the bottom of the optic nerve, they are in two forms. So in two big radiations. Now, if you compare the right eye with the left eye, you find that obviously there's lots more of blue, lots more of sky, lots more of ocean. Therefore, what is there? That means that these nerve fibers have died. This gives you an immense amount of information about how the nerve is like. Now, once you have obtained that data and you have seen that optic nerve head, now the statistical analysis now starts. It's going to compare how much of deviation has occurred. So here you have, this is the deviation map, thickness deviation. Remember, we are looking at thickness. So we find over here, what comes in red, look here in the left eye, what comes in red means there's immense amount of deviation. What comes in yellow, that means it is borderline. Once you have finished that, please don't forget to look at the profile map. Now, this is the profile map. This profile map is of immense importance because look at this. This is of the right eye where you find that there is one upper one and a slightly lower one. What is that? They are the two parts of the upper RNFL thickness. Now you come to the latter part of it and we find that this is of the inferior part. So now with the one which is of dotted line, that is of the left eye. So that is telling us what is the deviation. Now you're going to compare the two with the normative data and you what? Now this I will tell you, yes, what is in green is the normal people. What is in yellow is borderline. What is red, of course, is that it's absolutely, it's very highly diseased. So RNFL TISNET map is very, very important because it is telling you whether my data is falling in the normals or not. Please have a look at the left eye. In the left eye, over here, see, you have seen over here, this is blue. This blue means loss. Look at the, and over here also there is a lot of loss, especially this one. So you find that it is dipped in the red, and of course the lower part, it's almost gone. Don't forget these two maps, extremely important for segmentation purposes. Now let's go on further. You must know what is the normative data of your machine. The Cirrus OCT had 284 healthy individuals, age range, so between 18 and 84 years. Now suppose, for example, you have a 13-year-old girl who has a very large disc and large optic cup, and the person comes to you, then if you try to analyze this data, they are going to compare it with an 18-year-old. So please, this analysis is going to be fallacious. We have different ethnicities also, Caucasians, Asians, African Americans, Hispanics, but unfortunately, 1% of Indians only. Refractive error again is a wide range, -12 to +8. So if you have a highly myopic disc, remember that is not in your normative data. There is also an age-related reduction in the RNFL thickness. Don't forget about it. That is about 0.052 microns per year, and then the rest of it you can have a look at it. So now let's have a look at each segment. So the first thing is, of course, you've got the examination date, and you can see over here that the amount of signal strength is extremely good. It's 10 by 10. Now we have a look at the RNFL thickness, which I've already explained to you. So RNFL thickness map, this gives us the raw RNFL thickness using a color code without comparison with normal data. Always compare the two eyes and you will get information from here. Now look at the RNFL thickness map in a person who is normal, a healthy RNFL. Now gradually the RNFL is decreasing, therefore we're getting more and more of blue. Now we're getting moderate glaucoma, we're finding more and more of blue and loss of the hot colors, and severe glaucoma, you practically have no hot colors at all. Now you're comparing what is the neuroretinal rim thickness, very, very important, and here you find this plot which has been measured. It is showing you where exactly the loss has occurred, and with the normative data. Then the deviation match, which I've already talked to you about, and then again is the RNFL thickness map. And now we're getting going sector-wise. This sector-wise map is very important because it's going to tell you which clock hour your RNFL thickness has actually been lost. This is one thing that should never be forgotten, because these are the tomograms which is telling you whether the data has been correctly taken or not. And this thing also tells us whether the machine has done the segmentation very thoroughly of each and every part of the retinal layer. Now we come down to parameters which are very important to us for glaucoma diagnosis. I told you there were 3 parameters. ONH, this has the greatest diagnostic capability. But what do we see for that? We look at the vertical rim thickness, rim area, vertical cup to disc ratio. Then we look at the GCA. What is GCA? Glaucoma, the ganglion cell analysis. We are looking at the most important area is what? Inferotemporal area, average. Then we come down to super. So first here is inferior, which is very important. Then we come to the superotemporal area, and then the inferior sector ganglion cell thickness. Now the ganglion cell thickness is extremely important. Just have a look at the 2 yellow things. Now they're all yellow all around. Now this has an elliptical measurement annulus centered right on the fovea. Fovea is not taken into consideration. It's the area all around. After that comes the deviation map. How much of deviation has taken place between the normals and the patient here we have done. And of course, then of course is we are looking at the scan, that is the B-scan image. The B-scan image again is extremely important for us, right? Then we come down to, so this is an elliptical annulus, this is the deviation map, this is the ganglion cell thickness, and this is telling us what is the average and minimal ganglion cell layer in a plexiform layer. This is the image, a B-scan image. Now, look at this. This is a loss in the warmer colors. In a typical arcuate glaucomatous pattern, it is known as the nautilus or the temporal raphe sign, which is showing us a discrepancy in the anatomy of the RGCs. Now, this is an optoview scan. I'm typically showing you the ones which are more commonly used, Cirrus, and then comes the optoview. Again, look for the graphics, then look for the signal strength. Signal strength, as per manufacturer, should be 40. So there we were 7 above, and here we are 40. So this is no longer on the top. Now you go to the middle of the sheet. At the middle of the sheet, you'll find that it is 55 and it is 31. Now here, once you have seen that, after that, please don't forget that we have to now, it is comparing from the very beginning. Here the hot and the cold colors are not coming in, so that's a disadvantage. But now the immediate analysis goes in. I want you to concentrate definitely on this area. This area is the one that is giving you every parameter. How big is your thing? You have done a clinical examination. You've come to know that this is the size of your optic disc. Please have a look. Is your optic disc that size? It is large. Is it small? Have a look at the cup. Is the cup small or big as you have determined it? It'll tell you objectively what is the data over there. Now look at the signal strength. We had one patient whose signal strength was only, as you can see, 41.8. And we had so many defects in the right eye. Left eye was okay. Now we said, please repeat, signal strength very low. And lo behold, once we did it, we find everything became absolutely normal. So signal strength is that important. Even the signal strength for the, mind you, signal strength for your RNFL is different, for your ONH and for your GCC is also different. Here also we find that there's a significant difference once your signal strength improves. Now we come down to the GCC that is very, very important for us in glaucoma diagnosis. In an opto view, the RNFL plus ganglion cell layer plus inner plexiform layer is the composite composition of your GCC, unlike the cirrus. So this is how your analysis takes place. Yeah, and so I am finishing off, wrapping up now. So this is the significance map. These are tilted discs in high myopia and OCT showing you. You must be very careful in macular scan. Remember, OCT is of less useful when it is advanced disease. We have progression analysis in OCT also to help us. It can be an event-based analysis or it can be a trend-based analysis. And this is how the pictures look like. Have a look at it. It will help you. And you must not forget the red and the green disease. And one thing which has already been talked about by Dr. Hemlata is your anterior segment imaging. And I'd like you to show you something. It was a patient whom we could not see anything. The entire eye, the upper part was absolutely, it was opaque. Now we did the anterior ACE OCT. And you just looked at the video, I came to know what was behind that white colored thing, just like you people also are seeing it. Thank you so much for a kind hearing.